And what I'd like to do is to use the Pittsburgh database, Cohort, and some of the published literature to describe the risk of developing primary pulmonary hypertension in our scleroderma patients according to clinical subtype and autoantibody type, to look at survival according to autoantibody, and to discuss some of the associations of scleroderma pulmonary hypertension with non-scleroderma associated autoantibodies. So this is my concept of the clinical and serologic classification of scleroderma. On the left is diffuse disease, on the right limited, and at the bottom overlap. Those are our clinical methods of classifying the disorder. And then I've superimposed on this the autoantibody types that we most commonly recognize. At least 98% of our patients have a positive ANA, and 90% of those 98%, or 90% of 100%, have one of these 9 scleroderma-associated autoantibodies. We recently described a 10th one, which occupies another 1%. I think you can see that the bare spaces are overrepresented. These semicircles, ovals, should occupy 90% of the large oval. So we have 3 autoantibodies that primarily identify patients with diffuse disease, 3 with limited, and 4 with overlaps, particularly overlaps with myositis. And the ones that we commonly identified all have clinical correlations which are moderately strong. Anti-topoisomerase 1 with interstitial lung disease, anti-RNA polymerase 3 with severe skin involvement and a 25% risk of renal crisis, anti-centromere with pulmonary hypertension, anti-THTO with pulmonary hypertension and interstitial lung disease independent of one another, anti-U3-RNP with myopathy, cardiomyopathy, and pulmonary hypertension. I say myopathy because this is typically a bland process rather than an inflammatory process. Anti-U1-RNP, so-called mixed connective tissue disease with myositis and ILD, anti-PMSCL, myositis, anti-CU myositis, and anti-U11, U12 RNP with ILD. So I think that this is a disorder which is not a single one. It's a family of diseases. And I would urge that when we do basic studies that we at least pay attention to the opportunity to use these subsets separately from one another, because the lessons to be learned are probably more likely to be learned by splitting rather than lumping. In the Pittsburgh cohort, which began in 1972, to date, we used the standard methods to identify patients with pulmonary hypertension, either by cath or, if no cath, and that's not common today, but it was beginning in 1985 when we started this particular series of patients. We did use an echo with a PA or RV systolic pressure over 45. And we also defined secondary PAH and tried to distinguish them from the primaries. Well, these are the demographic and clinical features in our cohort beginning in 1985. And so you can see we have primary, secondary, and everybody else. And I've used primary versus all others for statistical purposes. Here I need to give acknowledgement to, there are only 3 people who saw all these patients, 3 rheumatologists. Besides myself, the other 2 are in the room, Ginny Steen and Robin Domsick. And so I have a great debt of gratitude to them for their contributions. Of course, you could say I'm naive because if I think that 2 young women are going to pay any attention to what an old man says, you're wrong. The other acknowledgement is to Noreen Fertig, who is a very talented research technician who did virtually all of our autoantibody testing, including those by immunoprecipitation, which isn't easy. So I think you can see here that primary pulmonary hypertension patients are distinguished by the fact that they have primarily have limited skin involvement. They, even if they are found in overlap, they are in distinction to secondary pulmonary hypertension, which are primarily, or not primarily, but disproportionately African American, male, and diffuse disease. According to the autoantibodies, and I've included the last one, the 10th one, which are antibodies to reptin and pontin, and identify a small group of males with diffuse disease who have a myositis. But these patients, the primary, have predominantly anti-centromere, anti-U3-RNP, and anti-THTO in comparison with all of the other patients. That's a typo up there. That should be 1,861 rather than 18.61. And in contrast, patients with secondary pulmonary hypertension who have pulmonary fibrosis as the primary underlying disorder have a disproportionate frequency of anti-SCL70. So centromere, U3, and THTO are the biggies. And if you put these numerators together with denominators for the whole series, you can get some idea of the risk. So I've ordered these according to the frequency with which pulmonary hypertension of the primary type occurs in patients who have these antibodies. So I think you can see there are 4 autoantibodies in which have the greatest risk, patients have the greatest risk of developing PAH, anti-U3-RNP, THTO, centromere, and U1-RNP. And numerically, centromere is by far the most common because it's the most common autoantibody. The rest tails off quite a bit. Now, these are underestimates because at the bottom here we have incomplete long-term follow-up. So 37% of our patients known to be living have not been followed for more than 5 years. So if I was going to publish this, I would probably have cut off the first visit entry so that the patients had 10 years of follow-up or 15 years of follow-up so that we could minimize the number of late developing pulmonary hypertension patients who might skew these numbers. But my feeling is that there would be very little change in the distribution of risk in these patients if we, even if we had longer-term follow-up. There was an attempt to identify risk factors from the Royal Free Hospital. This did not include all comers, but instead included consecutive patients who had either ILD or PAH. And interestingly, they identified RNA polymerase III antibody as a predictor. We did not. They did identify U3-RNP, and as in our population, which was 3% anti-SCL70, theirs also showed that anti-SCL70 reduced the risk of subsequent PAH. Looking at survival, I put together all of the patients with primary pulmonary hypertension that I showed you before, centromere, U3, THTO, and RNA pol3. And they came from patients who had one and only one antibody. I neglected to say when I had my diagram up there that very few patients with scleroderma have more than one of the 9 or 10 scleroderma-associated antibodies. Only 2% or 3% have more than one of those antibodies, so it's one per patient. Very dissimilar to lupus, where 3 or 4 recognized autoantibody systems are commonly found in an individual patient. So here I think you can see that the 1, 3, and 5-year survivals in our patients are in the upper 80% to low 90% at 1 year, go down to the 50s and 60s at 2 years, and fall even further at 5 years of follow-up. And we used as a starting point for follow-up the first documentation of pulmonary hypertension, right heart cath, or if no right heart cath, the echo. Importantly, these data are not adjusted for age, sex, or other organ system involvement, which are known to be risk factors for survival. This same type of analysis was done in the Pharos registry. The numbers are somewhat smaller, but here are the numbers of antibodies which were found. Again, centromere was the highest. This study was not able to distinguish the different types of nucleolar antibody, nucleolar staining antibody. So for purposes of comparison, I grouped our 2 major nucleolar staining antibodies, THTO and U3-RNP, together for comparison. The starting time was essentially the same. Here there was an attempt to control for age, sex, race, and duration of disease, and the 1 and 3 year survival rates basically are indistinguishable from one another. So just to compare the Pittsburgh data, I think it's basically the same. Ours is somewhat lower survivals, but again, not very much difference between those groups. Now, whether that's telling us that autoantibody type may be important in the very early stages of disease, and by the time advanced pulmonary hypertension has developed, the presence of autoantibody, or a particular one of these autoantibodies, is unrelated to the natural history, the late natural history of the disease. Antiphospholipid antibodies have been of interest because of the possibility of clotting in the pulmonary system. And here are 2 studies from France. The first has to do with anticardiolipin and anti-beta-2 glycoprotein antibodies measured in scleroderma, RA, and lupus patients. Anti-cardiolipin antibody positivity was lower in scleroderma compared to the other two groups. The mean ACL titers were lower, but positive ACL was associated with pulmonary hypertension. Again, small numbers, and does not apply to the vast majority of individuals with scleroderma who develop pulmonary hypertension. A similar study of ACL, beta-2, glycoprotein 1, or LAC positive from France, 13 out of 69 consecutive scleroderma patients had one of those three antibodies versus a very low proportion in controls, and pulmonary hypertension was disproportionately frequent in those who had the antibodies as opposed to those who did not. And the pulmonary hypertension patients had increased anticardiolipin IgG levels. Other antibodies have been implicated. These are two studies from Hopkins. The first is concerning glycosylation, which is a modification that has been implicated in regulating a number of biologic processes. Antibodies directed against 4-sulfated N-acetyl lactosamine were looked at. 15% of scleroderma patients had these antibodies compared to only 1 of 40 controls, and pulmonary hypertension was disproportionately frequent in those with those antibodies compared to those without. Antibodies to the nuclear phosphoprotein B23 were also studied by the Hopkins group and were found in 11% of scleroderma sera, but unfortunately the antibody alone can't be studied because 8 of the 10 patients identified also had anti-U3 RNP and 4 of the 10 had anti-U1 RNP. But nevertheless, pulmonary hypertension and severe pulmonary hypertension were associated with that antibody. There are a number of other studies on non-scleroderma specific autoantibodies, mostly from Europe, particularly France, Germany, and the Netherlands, and I tried to just summarize some of those results. IgG from affected patients binds to vascular smooth muscle cells and induces contraction. Anti-IgG anti-endothelial cell antibodies, AECA, also bind to microvascular cells both from the lung and the skin and induce apoptosis. These antibodies bind to microvascular lung and dermal fibroblasts, and a number of target antigens have been identified, which of course may be implicated in the pathogenesis by modifying vascular contraction. These antibodies from both scleroderma and lupus patients with PAH are implicated in the expression of cytokines and adhesion molecules, suggesting that their activation to a pro-inflammatory, pro-adhesive state. And then there are other receptors there are other antibodies to receptors, anti-angiotensin 1 and endothelin A, which also are believed to contribute to endothelial reactivity and the induction of a pulmonary vasculopathy. This is a case report in which we participated, an Italian investigator who had done plasmapheresis on a patient with scleroderma and pulmonary hypertension, asked us to look at the serum he had collected and to identify for him what the ANA titers and the anti-U3 RNP amounts positive, present or absent were. And so here you can see the plasma exchange administration. On the left is the pulmonary arterial pressure by echocardiogram. On the right is the heart rate. And I think you could see that after pheresis, the PA pressure declined to close to normal, but after pheresis was stopped, the PA pressure went up again, consistent with the symptoms that the patient had. Significant dyspnea to begin with. It went away, but then returned. And when we looked at ANA titers and anti-U3-RNP presence or absence, we found correlating with the clinical features that anti-U3-RNP antibody disappeared during the treatment process and then reappeared after the disease flared again. So I'm not advocating plasmapheresis treatment. Who knows what else was removed from the circulation with plasmapheresis that might have influenced the natural history of this disease. But it's just an example. So I will conclude by saying that primary PAH occurs most often in scleroderma patients with limited cutaneous involvement. Anticentromere, THTO, and U3-RNP are disproportionately frequent in these patients. The data on survival is inadequate, and probably there isn't an influence of antibody type on survival. But certainly autoantibodies may play a role in the pathogenesis of this disease. So I thank you for your attention, and I'd be happy to answer any questions.
Dr. Medsger, over here. I don't know exactly what's the frequency of lung transplantation in patients with scleroderma and PAH. Probably is infrequent.
We have some, but most of our patients in Pittsburgh's a large transplant center.
Yeah. So my question actually refers, if you follow up after transplantation, what happens with the autoantibodies or the specific antibody? Is it goes down or it stays up? Because it would argue that it's a primary intrinsic defect of the vessels in the lung rather than being the antibody.
We don't have those data. Unfortunately, we don't see the patients often after transplant. We do have the feeling, though, that that active disease does not occur after transplant. I mean, they are on immunosuppression. There are some studies that suggest if you lose autoantibody reactivity, your outcome is better. For example, in Japan, one of our former fellows, Dr. Kawana, did a study of 20 years follow-up study of anti-SCL70 antibody and found that in those few patients, 6 or 8, who lost their reactivity, they had stable, non-progressive interstitial lung disease and a better survival, whereas those who retained their reactivity did not. They progressed.